This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. Steve Love along with Thomas Miller, and we've got a great show for you today. Thomas, I'm real excited about hearing about arts and humanity in healthcare and also mindfulness.
We really stumbled onto a great topic that is going to, I think, leave people uplifted in this program. Yes, absolutely.
You know, we need some stuff to help uplift us too. As we look at COVID-19 and we're entering another week, a lot of things we've got to learn. And, we can even look back at history and learn a little bit.
Yes, absolutely. And as it looks like now, this is shifting on into May officially, and we'll know more as things unfold. But I know you went through, like you've been, as you say, you've been knocking on this door for quite a few laps around the sun. And you've been through a lot of other viruses and have a perspective on what maybe we can learn from the past.
Yeah, I think we can learn a lot from the past, and I've been around a long time, but I'm going to go back even before my time. I'm going to go back to 1918 when we really had a serious outbreak of flu. COVID-19, everybody knows. Where did it start, Thomas?
It started in Wuhan, China.
The big problem that we had with the virus back in 1918. Do you know where that started?
You got me.
Most people that research it think it's Haskell County, Kansas, right here in the USA.
Wow.
There was a mild H1N1 virus, and apparently they still think it jumped from an intermediary, which was a pig, to a human being. It infected an individual that went to a huge army base that was in Kansas. And then we were in the midst of World War I. Troops got on ships. Does that ring a bell?
Boy, we've heard that one.
And the ships were very close barracks, and they had an outbreak. And the fever was known as the 3-day fever. It was very mild. But then, Thomas, it resurged, and the second wave hit Navy ships, medical workers. The victims had a horrible form of pneumonia, even to the point they turned blue. It came to the United States, Italy, Mexico, India. And let me tell you what history tells you. It was spreading throughout the USA, and the public health director in a city immediately quarantined naval installations and made people wear masks. Guess which city that was?
I have no idea.
San Francisco.
Wow.
Now, who was the first mayor in the COVID-19 to order a citywide lockdown?
Oh, isn't that something, how history repeats?
The mayor of San Francisco.
Yeah.
And then there was a wave 3. People opened things back up. In Savannah, Georgia, the crowd started gathering again, and they had to reclose everything because they had a resurgence. Now, Thomas, I'm not trying to preach doom and gloom here at all. We've got so much more modern things because, unfortunately, in the virus I was talking about, there were many, many people, over 50 million people that died between 1918 and 1920 throughout the world. So what I'm saying is we got to be careful as we open things up. We've got to look for the resurgence, and we've got to learn from the past.
That's absolutely true. And what we tend to forget is that virus lasted 3 full years because the outbreak was in early 1918. So we're talking,
that's correct.
We're 6 weeks into this thing. Now, I would wonder, because the other side of this coin is obviously the economic impact. And I know that's what people are starting to talk about and be very concerned about. As we look back at that situation, and obviously economies are as you say, different today as well. What are your thoughts on how we balance those two?
It's very difficult. Hospitals are large employers as well. In many of the cities we serve, we are the largest employer. We also understand the public health aspect. Our hearts ache for the business leaders in our community, the small business owners, people that own restaurants, taverns, bars, people that own hair salons. Hopefully we can strike a balance where we serve the needs of the public health, but we gradually get this economy going, because it is such a economic disaster right now, and we're all in this together.
The hospitals have a pretty unique position in this, or perspective, because they're looking at it not only as you say, sometimes a region's largest employer, but also they are losing, I think you said, up to 80% in some cases of their revenue.
Absolutely. Many of the hospitals, especially the rural hospitals that have elective surgeries, I think most people know this, but elective surgeries are a pretty high margin book of business for any hospital. And hospitals, of course, appropriately so, shut that down. But it's impacting all hospitals financially. Hospitals are taking, because of volume, because of expense, and because of loss of revenue, they're taking a pretty big financial hit.
So they're looking at this from the public health perspective. They know what treating this involves, and they're looking at it. They're looking at their ledgers, and they're seeing the same thing that you and I are.
Absolutely. Absolutely. They want to do what's right public health wise. They want to do what's right for the community, but they also want to be sustainable so they can deliver the services that they've always delivered.
So in a quick word and a tease for our next segment, what are some of the solutions that are on your mind?
I think we have to do this very gradually. I think we have to do it in a way that we test, we monitor, we put surveillance out to see how things are going, and we gradually open up the economy. I think that's smart, Thomas, because if we do it all of a sudden, and we have what I described in 1918 in Savannah, Georgia, a big outbreak again, we're back to square one.
All right, let's continue this conversation in the next segment. And one of the areas that we have to explore is additional testing. So Steve has some thoughts on that. And then later in the program, we have two really good interviews. Dr. John Harper over at Texas Health Presbyterian Dallas is a cardiologist, but he is also very into the arts, and he's going to share that passion with us. And then to wrap up the show today, Beth Warren is going to be talking about mindfulness, and we just applied it right over to COVID-19. So that's coming up next on the Human Side of Healthcare here on 1080 KRLD and radio.com. Plus, you can catch the show and all of our extended interviews on our podcast. It's on all the major podcast players. Just search The Human Side of Healthcare. Quick break. We'll be right back.
This is The Human Side of Healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
And welcome back to the Human Side of Healthcare. Thomas Miller along with Steve Love. And we're continuing our conversation about Steve's thoughts and some of the local implications of where we are this week with COVID-19. Steve, those were some interesting stats that you had for us in the last segment. Where did those come from?
Oh, they came from a book entitled The Great Influenza. It was authored by John M. Barry, and he's done a lot of research. And really, it's so interesting to go back. What a tragedy. That was actually a mild H1N1 virus that started that great influenza. And unfortunately, it went worldwide. Now, I'm certainly not saying that's the same as COVID-19 by any stretch, but I still think we can learn some lessons.
Now, you've been through some of these other big pandemic or outbreaks and pandemics that we've had in modern history. Why is this one so bad that we've shut the whole world down for it?
And when I talk to epidemiologists and I talk to infectious disease doctors, there are a couple of distinctions that really jump out at me that I've learned from them. First, it is so contagious. It is very, very contagious. It was a novel virus, and there were no real antibodies around to help people prevent it. I think that's number one. Number two, we're still learning about this virus. From what the infectious disease physicians tell me, if you go back to SARS and MERS, it's kind of like, yeah, they finally got a vaccine, but they kind of ran their course and that was it. You're already hearing many of the people that deal at CDC warn about we could have a resurgence. This could come back in the fall. It may come back right in the middle of flu season. These are the things that really set it up differently than some we've dealt with in the past.
So as we think about, boy, I've been pondering this. I know you have relentlessly, and I think everybody listening to this has. How do we get back to some kind of normal when, and what is that going to look like? So one of the things that I've been thinking about is how do you bring a group of people together? I mean, we can go back to normal if we just kind of open more businesses but do what we're doing. I think we'd probably be pretty safe with that. The drive-by retail that we've been talking about and continuing all of the things that we're doing now, but just start to expand what can be open. Okay, that's one possibility. But if we start talking about church or we start talking about any group of people, and I'm talking about people in a corporate building, that looks pretty dark to me. So how do we do it? Testing?
I think testing is certainly something we're going to have to do and do surveillance. By that, I mean, make sure you're not getting hot spots. I don't really know the answer to that. I think we're going to learn as we go. I heard today an expert in the sports world who truly believes that many of the sports programs are going to come back, but they're going to be played in empty arenas. They're going to be televised so people can see it, but they're not going to have the large crowds, and they're going to have to gradually, as a vaccine is developed, et cetera, they're going to gradually bring back the way we have thought it. And I don't know if that's how church will be done or not either. There'll probably be a lot of social distancing when you begin church services again. Office buildings, I think we're going to have to practice really good health habits. And, Thomas, part of the problem is testing. You've heard all the talks about the initial tests were contaminated. And then we had additional tests that had to be made. And now even some companies are coming up with tests at home. One of the things a lot of people may not have known that also complicated this, companies made tests, but here's the deal. Private labs in this country process about 2/3 of all the tests. Okay, that sounds pretty good. But most of the companies that sell those testing machines also sell the chemicals or the reagents needed to process those tests. So if a lab gets real backlogged, they have to get the specific reagent that's compatible with the piece of equipment that was manufactured. That slows up the process also. You can't just take one reagent and use it in all tests. So there's a lot of things that we're just going to have to work through, do more testing, do more surveillance. And I hate to use this analogy, kind of put our foot in the water and check it gradually as we go.
I know you've been involved in a lot of high-level meetings that are having the conversation about when and how can we bring this back to some kind of normal. Can you bring us up to speed on kind of the latest of that conversation?
Yeah, and I think, and I give a lot of credit to the infectious disease doctors, the epidemiologists, the public health departments, the county judges. The county judges have been having weekly phone calls. They've been sharing best practices, talking through what they need to do. I mean, this is all new to everyone. I mean, most of the folks here obviously didn't go through this in 1918. They may have gone through H1N1, they may have gone through SARS, et cetera, but nothing on this scale. So I think the way people have shared their thoughts, their ideas, their economic thoughts, their public health thoughts has really been very good. It's been a healthy discussion, but I think constituents are really beginning to make a lot of noise about, we want this economy to turn around, and we've got to do it in a balancing act, and that's going to be difficult.
You mentioned in the previous segment about the hospitals closing and now thinking about reopening elective surgeries. What would that look like?
Let me kind of take elective surgeries and put it in a couple of buckets, if I could, for the listeners. There are elective surgeries that may be cosmetic and those kind of things, which are great, but that's not what I'm talking about. I don't think you're going to see a lot of cosmetic type surgeries done for a while. But on elective surgeries that I categorize as urgent, maybe they are not only surgeries, but diagnostic procedures like MRIs, or things that we have to do, a procedure like a colonoscopy. Those are very important tests. They're important procedures and surgeries. For example, if you had a melanoma, you certainly would want to have that removed. And that would be a surgery that wouldn't necessarily require you to be hospitalized, but nonetheless, it's a form of elective surgery. I think you're going to see all the hospitals, as they bring back the urgent surgeries or the urgent procedures, they're going to develop a framework where they prioritize those surgeries so that the most important, the most serious get done first. They also are going to have to do work to ensure that they protect the patient, they protect the healthcare worker, and they protect the very institution, the hospital, so that we don't have spread of COVID-19. They're going to have to increase screening. We just talked about testing. They're going to have to make sure that they have good tests related to those patients and to the healthcare workers. And they're going to have to use what I call hospital and outpatient surveillance, where they monitor the procedures, they monitor the surgeries, and they make sure that there's no increase in COVID-19 infections. And at the same time, ensure they have enough personal protective equipment, PPE, to safely perform the procedures or the surgeries. So that's a lot that I just packed into that. But I think every hospital is going to be very cognizant and careful to protect the patient and the worker.
Another area of medicine that I know people are concerned about, people have chronic issues that require regular labs and doctor's office visits. Are we going, basically, would you say the same thing about opening up physician practices for routine chronic management?
Yeah, I think absolutely you could open physician offices. And you bring up a very valid point. Chronic illness, we've got to stay on top of, because if you should contract COVID-19, it makes it worse. The main thing, enough PPE, enough testing, ensure they protect the patient and the healthcare workers in those doctors' offices.
Absolutely. And protecting the other person is our primary concern as well as ourselves. All right, let's change gears. There's a wonderful program over at Texas Health Presbyterian Hospital, Dallas, that combines arts and humanities and medicine. Everything from music to dance to poetry to literature. Dr. John Harper is a cardiologist there who has a passion for beautiful prose. And you'll hear how he weaves it into daily conversation to draw on the wisdom and eloquence of those who have come before us to help us speak, live, and think better. And Steve, that's something that we really can use in our society today.
Absolutely. And if you're at home, staying at home because of COVID-19, this is made for you.
The arts and medicine next on the human side of healthcare on 1080 KRLD, radio.com, and your favorite podcast player.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to the human side of healthcare, Steve Love, along with Thomas Miller. And we're going to talk to you today on the human side of healthcare about art in health. And you may say, art in health? Well, we've got an expert to be talking about this subject. He's Dr. John Harper, a board certified specialist in internal medicine and cardiovascular diseases. And he's a cardiologist on the Texas Health Dallas medical staff and a member of the Texas Health Physicians Group. Welcome, Dr. Harper. We're glad to have you.
Well, thank you. It's a real pleasure to be with you.
You know, when we think of this topic, arts in health, how is arts in health defined, or how does it affect us from a mental, physical, or spiritual aspect as individuals?
Well, we work off the World Health Organization definition of health, which is a state of complete physical, mental, and social well-being. It's not just merely the absence of disease or infirmity. We're not looking just for a technical answer to a problem, but trying to work with the entire person to heal the whole person. And that's the definition we use of arts and health.
So when you look at the arts and health, when did Texas Health Presbyterian Hospital in Dallas begin this journey of arts in health? And why did you do it?
Well, independently, there were 4 different programs at least working. Art programs, dance, music therapy, and then literature and medicine, which I've been involved with for many years. We felt that in December of 2018, there would be advantage in putting these programs together, coordinating their efforts, doing it all under one umbrella. Also looking for funding and ways that we could make this incorporated into the daily work of our hospital. It's important to know that when we're talking about arts and health, we're not just talking about the health of patients. This is also for physicians, nurses, caregivers throughout the hospital. They need this support of arts as well. When we talk about arts, it's a broad topic. It can be art itself, music, dance, sculpture, literature, many, many different things. I was going to say, we know that some of these things can actually improve outcomes in patients. It can shorten hospital stays, reduce pain, improve cognition, and it may promote the health across their entire lifespan. So these are the reasons we're doing it.
You know, it's fascinating as I hear you talk about the art, the dance, the literature and medicine, the sculpture, how it not only impacts the patients, but the physicians and the staff. And I was kind of thinking, you know, as we're going through this COVID-19 problem and people are staying at home, you know, they get cabin fever. Could any of this art, dance, literature be adapted where people could do some at home? I was just kind of thinking out loud. Do you think there's a way to connect that?
I think there is. There's a beautiful article by Dr. Siddhartha Mukherjee talking about Anton Chekhov and Chekhov's life. Chekhov was both a physician and a writer, a world-famous writer. He talked about in his existence in Moscow and later in Sakhalin Island how there was a social numbness. There was so much going on in the world that was bad that it was overwhelming. Very applicable to what we may all feel today. In a beautiful essay, Mukherjee talked about this and said, what is the only way we can treat anesthesia or numbness? And he says it's aesthesia, and it's beauty. And we have to look to beauty to help us get through these times. And I've sat myself and reflected, sitting listening to Barber's Adagio, reading my favorite book, looking impressionist art. These things are a way through the numbness we feel in our society, both for the physicians, nurses, healthcare workers, and people in general. So I cannot think of a more appropriate time for people to be utilizing this, Steve.
That's amazing. In terms of art and art therapy and dance therapy, hopefully most of our listeners understand that. But can you expand a little bit on the importance of literature in medicine?
Yes, I have been impressed as a young boy how important it was to read about medicine. We think that medicine is basically a communication skill. We have to listen to our patient. To paraphrase William Carlos Williams, every patient has a story to tell, and they want you to hear it. But then we have to communicate back to the patient. And we as a physician are doing that. Physicians are doing that less well. And we think, therefore, that we have to come up with a way to intersect really good medicine with good communication skills, and literature is a great way to do that. We have the opportunity to use the synthetic and expressive genius of other people that have come before us. As a quick example, I was trying to explain to a wife of a patient who had had a 12-week hospital course, was near death for many weeks. She came back to me and said, "John, thank you, but you were so serious the whole time." And I could have explained about intensive care units and pressor agents and Apache scores, but instead there was a line from poetry from Antonio Machado, and that line is, "The sound of a coffin hitting the earth is a sound utterly serious." And she went, "Oh." And the beauty of that was somebody else had done the hard work for me, and by reading it, I could use that, and in a few words, expressed far better and far more clearly than I could have in 20 minutes of talking.
Wow, that's really an example that kind of sticks with you in the seriousness of it. Thank you for giving that example. You know, when you think in terms of arts, humanities, and medicine, and how you're describing how it's used, how receptive have North Texans been to arts and health in this initiative thus far?
I think we would have to say very receptive. We've had focus groups among 2,700 active volunteers, and a large proportion of them indicated a great willingness to be involved in this, and about 60% suggested they would be willing to give financially to do this. Our literature and medicine program has been very well attended, usually between 200 and 250 people a year. We have a writing contest and have had entries from all around the world. We have juried awards in short stories, essays, and poems, and people keep calling and asking when our next meeting is. So I think that people understand the value in this, and we have a yearly schedule we've worked out now. Catherine McDonald has been a driving force in this, along with Dr. Anna Singh and Susan Miracle, and we have monthly concerts in our lobby. We have the Nutcracker Suite in December. We have our literature and medicine meeting in October. So there's a real want out there in the world for us to go forward with this.
You know, as you were just talking, and I was thinking, what a great program in the acute care setting. But this would really work post-acute as well. I can only imagine in some of the post-acute settings how this would really be the arts and humanities that especially people, say, in skilled nursing facilities could really enjoy, and it would be inspirational. Your thoughts on that?
Totally agree, and I think it will be inspirational, but there's good evidence that it also has medical benefit. People with movement disorders like Parkinsonism can learn to dance, and they have much better control of their body dancing than they do with other activities. Post-stroke patients can learn to sing even if they can't speak well. These are real valuable tools for people as they recover from illnesses. And it is such a time of isolation when you're recovering from an illness. And one of the thoughts we have in literature and medicine is a patient is saying, "I need you," and our response as healthcare workers has to be, "I'll never leave you." So coming to them after the acute illness, staying with them during their recovery can be a real memorable and important moment for them, and quite frankly, for those of us that give healthcare as well.
You know, as you mentioned that, and talking about isolation, our hearts go out to some of these COVID-19 patients, and you hear the stories, and you certainly work in healthcare on the front lines and see it. How many of these COVID-19 patients have been isolated, obviously for health reasons, but nonetheless, the point you gave about how you relate to your caregivers is so important. Let me ask you this. Texas Health Dallas, how do you determine which arts and health and activities to implement?
We have a regular, at least monthly meeting where we have about 35 people come who have come voluntarily without reimbursement for their time. And we sit around and talk about what things that would be valuable. What is there literature to support that it's useful and scientifically valid? What do they have an interest in? And what do we think we could do to spread the desire here? We've been impressed, Steve, as we do this. People will come up and say, "Oh, I'm so glad you're doing this. Could we be a part of it?" That's why the committee has gotten so large. But we then vote on what we think would be valuable arts and health roadmap items. We come out with a schedule for the year. For instance, the University of North Texas Music Department is now coming once a month to have a concert in our lobby. We have Voces 8, which is a world-famous a cappella group that came last year and will be coming back this year. All these things are what we're doing, and people seem to want to be involved in a very deep level.
Do you have a touching story from a patient that was really touched by this?
Well, let me give you the one that caused me to get involved with, and it was my father. I grew up in West Texas, a little town called Pecos, and my dad was my hero, and I thought he was invulnerable. He'd been a professional basketball player, big, strong fellow. He developed an illness that made him cry out in pain at night, and my mom would get up and call the local general practitioner and say, "Bruce, could you send something out?" But rather than sending something out, about 10 minutes later at 3:30 in the morning, he'd show up at the house dressed in a three-piece suit, his hair combed, carrying a black bag. He would come in and greet me, greet my sister and my mom, and put his hand on my dad's shoulder. Say, "Frank, it's okay. I'm here now, and I'm going to stay till you're better." And then he would. And for a young man looking at careers, I saw that black bag as science. The fact that he was willing to get dressed, sit with my father till he was better, is compassion. And I thought it was a beautiful blend of the things that make medicine really a noble art if practiced well.
And if you were uplifted and want more of that conversation, it's on our podcast, The Human Side of Healthcare, on all the major podcast players. Now we're going to stay on equally high ground. When we come back, we're going to meet Beth Warren. She's a clinical therapist at Children's Health and has some great tips and techniques to bring us mental balance during these difficult times. And The Human Side of Healthcare will be right back.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environments. This is The Human Side of Healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to The Human Side of Healthcare. We're delighted you're with us today, and we have a very important segment that we want to talk about. Yes, it's called mindfulness. And we couldn't have a better person than Beth Warren. She's a clinical therapist at Children's Health. And Beth, welcome to the show.
Thank you. I appreciate it.
What is mindfulness?
Mindfulness means maintaining a moment-to-moment awareness of our thoughts, feelings, bodily sensations, and surrounding environment through a gentle, nurturing lens. When we practice mindfulness, our thoughts turn into what we're sensing in the present moment rather than rehashing the past or imagining the future.
So let me ask you this. As you look at the components of mindfulness, could you break those into different categories? So what are your thoughts on as we examine mindfulness?
Sure. There are usually three components of mindfulness. The first one being attention, and that is just mindfully paying attention to your inner and outer experiences in the present moment. The second part is intention, and your intention is what you hope to get from just being in the present moment, whether it be reducing your stress or trying to find peace in the present moment. And then the last component is our attitude. Mindfulness plays a really important component in attention to the way we see things and our curiosity and acceptance and our kindness that we give ourselves.
You know, in listening to those last two components, one, intention, where you think in terms, as you mentioned, reduce stress, and then the third component, attitude. I was just thinking what we're going through with COVID-19 right now. Do you have any thoughts related to mindfulness and maybe how it could help reduce stress and really help us with our attitudes, especially with many having to stay at home?
I think the simplest of mindfulness right now is just, for example, today it is an absolutely gorgeous, beautiful, sunny day outside, and just taking a minute to walk outside, to take a deep breath, look at how blue the sky is and how green the grass is. That is a simple practice of just practicing mindfulness today and the anxiety and stress of what's going on with COVID-19. Just realizing that it's going to be okay. we have to take a deep breath and just relax for a minute. Everybody's doing everything they can to keep us all safe.
That's some good advice. And, you mentioned practicing mindfulness. What kind of training do people need to practice mindfulness?
Really, you don't need any kind of specific training. It is nice to have a mentor or an instructor in the beginning to just kind of help you get used to it. But basically, the only practice you need is time and quietness so that you have a chance to just quiet your mind and get still for a minute. So just taking a minute to get quiet and take some good deep breaths is the simplest way to practice mindfulness.
Well, you're a clinical therapist, and we deal with many people around hospitals and in the healthcare field. Do you ever get a question like this? So, Beth, is mindfulness evidence-based?
Absolutely, it is, and I do get asked that a lot. Probably the two most evidence-based, research-based mindfulness methods are mindfulness-based stress reduction, which is done by John Kabat-Zinn. And then the other research-based, evidence-based therapy is mindfulness-based cognitive therapy, which is done by Segal, Williams, and Teasdale. Those are the two most probably heard of therapies and mindfulness practices that most people will recognize probably.
What are the requirements they have to change, or do they have to make a complete lifestyle change? What are your thoughts to enhance mindfulness?
Mindfulness doesn't really require you to change anything about yourself. Basically, what you're doing in mindfulness is just truly paying attention to the way you think, the way you feel, the way your body reacts to everything. Mindfulness recognizes and cultivates the best of who we are as human beings. The most change that you have to do is just making time to do it.
If you're looking at some of the techniques associated with mindfulness, what is one simple technique that we could use?
Probably one of the easiest techniques I teach is called GLAD. It stands for grateful, what I learned, what I accomplished, and what I delight in. So every day you do a GLAD technique. So you're going to say one thing that you're grateful for, one thing that you learned today, one thing that you accomplished today, and one delight you had.
It sounds like mindfulness helps put you at ease and at peace. And from where you are as a clinical therapist, what would you consider the ultimate goal of meditation?
I would say probably the best goal is reducing your stress and your anxiety and just finding joy in the day by slowing down and taking time to just recognize where you are and what your surrounding and your environment is, and just practice gratitude. That is one of the best mindfulness techniques you can do.
As I listen to you, and I'm thinking in terms of many of the listeners are probably at home. And, some of these techniques that they could be using at home where they feel more constricted than they normally are would be very worthwhile. And meditation would be one of those. Would you agree?
Yes, definitely. Meditation is one of the mindfulness practices that you can do. Mindfulness is just truly, and so is meditation, truly just being aware of your breath and your surroundings and the stillness that goes with it. So, we live in a very fast-paced society, and a lot of times, we're just on the go all the time. So making time to just slow down for a minute sometimes is really all we need to do.
Beth, Thomas Miller here. I know one thing: when people quiet their minds, they can sometimes just get freaked out by all the stuff going on around them. In other words, noise is sometimes a nice distraction. What do you say to them?
I think probably first and foremost, it's hard to turn off that anxiety when I am possibly going to lose my job or not being able to be around other people. So I think one way you can practice mindfulness is just to give yourself a second to acknowledge that the fear is there, to label it, to name it, so that we know where it's coming from. And then that way we can combat where is it coming from. Is it unrealistic fear? Is it real fear? Where do we go with this? And a lot of times when we get quiet and we name an emotion, a lot of times that settles us down because we know where it's coming from. It doesn't, always solve everything, but at least I know where I'm at and what that emotion that's rising up inside of me that's could be causing extra anxiety or extra stress.
When people contact you and they are genuinely concerned right now, what do you tell them?
First thing, that you have to acknowledge that you're scared and what you're scared of. If it's losing your job, absolutely, that's a realistic fear to be concerned about. And what do we have control over now versus what do we not have control over? And part of that is just sitting down and walking with the individual to kind of see if we can help label it and address it and kind of talk through what's causing all the anxiety. If I am losing my job, then, how am I going to pay my mortgage? And then, we kind of brainstorm on different ways to get income in if we need to.
Thank you, Beth, for that information. And her full interview is on the podcast, The Human Side of Healthcare, on all the major podcast players. Next week, we're going to look at ER and trauma through a different lens, not of COVID-19. That's going to be an interesting conversation. Please stay safe, and we'll see you back here again next week.